gender non-conforming populations. And it's going to be by Mika. Mika is our PA student. We have two, actually. The other one is also on, Marianne Adid. So this was a talk that she's pulled together over the last few weeks, so she'll be very good. Also, I have a special guest, Eric Hoagland, who's going to talk a little bit about the care in the transgender population as well. So next slide. So hitting the announcements quickly. We have a ton of talks coming up. And actually next week is going to be very interesting. I actually spoke with Matt about addiction care in New Zealand and opioid care in New Zealand. So it's going to be kind of interesting for us all to hear about how it happens in some different countries. Quite interesting. And then we have Isaac Marslick coming on the Wednesday after that. So as you can see, we've got a lot of great talks coming up. Next slide. I think Noah's running the slides today. Remember, there's free CME. If there's somebody else in your room, please make sure that you let us know so that they can get CME also. And again, please feel free to turn on your video because it's so much more fun if Mika and Eric can see you and they're talking to somebody and not a black box. So next slide. And again, if you need any help, we get a lot of phone calls from people. We're always glad to help you through some of those difficult patients. Our phone number's there. And of course, you can also call Erin, our program manager / nurse. So feel free to reach out. And again, this is almost up. There's a bunch of stuff on CORE on the Center for Opioid Resource Education. Go to that website, lots of different tools. The manual will be up in not too long. We keep saying that, but trust me, it will, but it may take a bit here. The podcast, actually, we just did the podcast just came out with the rural populations and opioid use. So feel free to listen to that. Again, there's 143 different topics on there and we're constantly updating them. So if you want a little bit more information, please go there. Okay, so today we're going to have Mika, and she's going to talk a little bit about substance use disorder in the transgender and gender nonconforming populations. And again, we have a special guest as well, Eric Hoagland, and we'll let him kind of tell him about himself as well once Mika gets going. The way this is going to play out is Mika's going to start the talk, and then we're going to bring in Eric, and then we will finish some of the other information from Mika after that. So Mika, I don't know if you want to introduce yourself a little bit more than that, sure. But she's a PA student from Augsburg PA College.
Yeah, my name is Mika Muris. I'm a PA student, and I go to Augsburg University in Minneapolis, Minnesota. I am a second year PA student and I will be graduating in August. So I'm looking forward to that. So I'm just going to kind of start out by giving a couple of definitions about terms that are used in a lot of studies that are done on transgender and gender nonconforming populations, just so that we're all on the same page. And then following that, we'll go through some of the reasons that transgender people might experience increased prevalence of substance use disorder. And then following that, we'll go over the prevalence and then right after that, we'll look at mental health in transgender people after they receive gender affirming care. So that's kind of how things are going to play out. And
next slide. Okay. Just tell Katie to run.
Yes. Okay. And then, so these are some of our objectives. You can just take a quick look over those for like 5 seconds, and then we'll go on to the next slide. All right. So first, we're going to start off by talking a little bit about the difference between gender identity, sex, transgender versus cisgender, and gender nonconforming and non-binary people. Gender identity is the innermost concept of oneself as female, male, or a blend of both or neither. And it's how individuals perceive themselves or call themselves. Whereas sex is male, female, or intersex, and it's a term that doctors use to describe a child really based on their external anatomy, and then also based upon chromosomes. Cisgender is a person that's gender identity aligns with their sex at birth, whereas transgender gender identity or expression that is different from cultural expectations based on sex assigned at birth. So then we'll get into the gender non-conforming and non-binary definitions. We'll start with gender non-conforming. It is a broad term referring to people who do not behave in a way that conforms with the traditional expectations of gender, or gender expression does not fit into a category neatly, which is kind of an umbrella term that's used for non-binary people and genderqueer people, and people that say that they like don't identify with gender. So non-binary people may identify as intermediate, or a separate third gender, or identify with more than one gender, or have like a fluctuating gender identity. So, and it's important to distinguish that gender identity is separate from sexual orientation. So some people that are trans say that they're queer, and some people that are trans say that they're straight. And so it's just important not to assume in that regard. Next slide. Thank you. So as I identified before, some non-binary people and gender non-conforming people do identify as trans, but not all do, because some people feel as though they were born non-binary and don't necessarily need to, there's not a transition that goes on. They feel comfortable without saying that they're transgender and just saying that they're non-binary. So that's something that's important to distinguish. I think a lot of people, a misconception is that all trans people all non-binary people or gender non-conforming people are transgender. And I think that's something that's important to distinguish. And let's see, I linked up there the Human Rights Campaign. It's just a glossary of terms. There's a lot of different glossaries, so I just linked that one. It's a good one. It has like a basic list of terms. But yeah, if you have any questions about what a term means there's plenty of glossaries online that you can reference.
Would you say it's often people mix these up?
I think so. Yeah, I do think that often people will mix them up, or they don't understand that there's overlapping identities too. And I think that that's something that I think sometimes people see it as all or nothing, or you're one or the other, and sometimes there's intersection in identities.
Okay.
So yeah. Let's see, and then the next slide. Thank you. So we're going to talk a little bit about mediating factors for substance use disorder in transgender and gender nonconforming populations. The higher prevalence of substance use disorder among transgender and gender nonconforming individuals is thought to be due to a kind of a combination of the following social and environmental factors. So the discrimination, lack of access to care, healthcare, lack of social support, and then stigma. And then even layers of stigma. So if somebody has a substance use disorder and is transgender, that's 2 layers of stigma that they're already dealing with, especially in a healthcare setting where you have access to their whole chart. Next slide, please. There's multiple different kinds of stigma. There's enacted stigma, internalized stigma, social stigma. So the enacted stigma is experiences of discrimination and rejection. Internalized stigma is shame and self-devaluation. And then social stigma is awareness of the prejudice. And then we kind of already talked about layers of stigma in the previous slides. These are, to the right is a couple of trans or non-binary celebrities. I don't know, I just included those because I think it's important to see that there's people that are in the media that are trans, that there's trans representation everywhere, and sometimes you just don't know. And next slide. All right, now I will introduce Dr. Hogland. He is a doctor in the Twin Cities at North Memorial Health Clinic. He works with transgender individuals, and I rotated with him for my first rotation, which was in family medicine. And so we got to know each other there. And yeah, so I would love if Dr. Hogland would give us some of his insight and expertise into some of these issues.
Okay, well, thank you very much for that introduction. So yes, my name is Dr. Eric Haugland. I work at the North Memorial Clinic in Brooklyn Center. And I've been with North Memorial since 2008. It's where I did my residency, and I've been here since then. I actually grew up on a little farm in Northwest Iowa. So suffice it to say, I would never have thought when I was growing up that someday gender care would be an area of expertise, niche area for me. But I think it's the best job in the world. I love being a family medicine doctor. I love being able to help with patients with primary care and all sorts of things. And a big part of our model is just, saying that we think we can do good gender care under the roof of a regular primary care clinic. So I'd say we were one of the relative leaders in the Twin Cities area about the move that we see a lot more commonly now of integrating gender care back into the world of primary care, as long as it's with providers and staff who understand trans people and go to all the conferences and all that kind of stuff. But we do a lot of the hormone management that used to be kind of farmed out to like specialty care kind of models. Just sort of bring that back into the world of primary care. So we do, not all of our visits are for hormones and such too. A lot of it's the diabetes and blood pressure management and other maybe mental health issues that have been coming up and such too. So I love my job. I work with students all the time too. And so one of the things I love is being able to introduce a lot of the various med students or PA students or nurse practitioner students to a little bit more of a diverse patient panel and just kind of see all the possibilities that are out there and get a little bit more exposure and a little bit more knowledge about the gender diverse community. So.
Can we ask questions? Because boy, I have a bunch. I don't know if Heather's going to ask some as well, but would you entertain some questions from the group as well?
Yes, absolutely. I would do much better. Like I can kind of give my little spiel, but in general, the idea of just answering questions is much more appealing to me. Yeah. Yeah, for sure. So anytime anybody has any questions for me, please feel free to ask too. Okay. But it looks like, Mika, do you want me to just go into the next question here, or is that?
Yeah, great. Yeah. So the next question is, what has your experience been with this patient population, which you kind of already told us a little bit about, but then do you see patients with substance use disorders in your practice regularly or ever?
Yeah. And so at this point, I'm a primary care and it's family medicine. So it's, probably about 2/3 of my patients or so are gender diverse, but not always. And it's still family medicine. So a lot of times it's also the spouses or the kids of my trans patients. And I still have a fair number of legacy patients from earlier on in my career when I had the capacity to see anybody that wanted to see me. But yeah, substance use disorders in my practice, yes. I do. I don't necessarily consider myself an expert on substance use management. I do what I can, and I'm lucky enough to have a lot of other resources that I can involve if somebody needs a lot of higher level drug management, and Suboxone and that kind of stuff. Yeah, and one of the really cool things about, I don't know, it sounds like that's kind of a diverse group here that's online. Probably not everybody knows that in the Minneapolis-St. Paul area, we have a very unique program called the Pride Institute, which is an inpatient substance abuse rehab center for the LGBTQ community. Which is so it's a pretty unique model. There's not very many sites that sort of specialize in helping people who are in the throes of addiction for this kind of underserved population. And so Pride Institute gets people from all over the country who hear about Pride Institute and come to the Twin Cities for assistance with those kinds of issues. So a fair number of those patients actually just stay because there's also sometimes kind of a coming out process that can happen when you start really acknowledging what's really going on and the source of your addiction and maybe the source of your mental health issues. And so I've been lucky enough to get a fair number of referrals from Pride Institute in the past too. So patients often who are working on their substance abuse and kind of in the new stages of recognizing, what some of the underlying issues have been and sort of transitioning. And many of them have ended up staying around the Twin Cities. So one of the really cool things for me has been being able to see some patients really get a new handle on their life when they start attacking all of these kind of things that have been getting in the way of them living a full and healthy and productive life. So,
yeah. Heather, did you want to ask your question?
I do. So, hi, thank you so much for being on. I'm sorry I'm not in person today. My question is back to the whole substance use disorder thing. Do you have any specific screening tools you use when working with your patients? We were talking about this with Mika yesterday or Monday about how just in primary care in general, because that is what Kurt and I started as, I don't think there should have to even need to be special clinics for substance use disorder or for, gender non-conforming patient populations. But for those who are in the work and or in your specialty clinic, do you have specific screening tools you use for things like substance use disorder?
is that a question for me or for?
Sorry, yes, that was really long-worded. That is for you. Do you have any special screening tools you use, to kind of help identify that subset of patients in your patients?
Yeah. Anytime we do an intake, we have some pretty thorough forms, and like for me, intake appointments are an hour and a half for my gender diverse patients. The intake appointments are an hour and a half long appointment. So I get a really thorough social history, and I would say that I usually have a pretty good sense of some of those kind of things that would be going on. In addition to the fact that they're filling out a form that specifically asks about drug use and alcohol use and substance use and things like that. I know you can't always expect people to be completely honest on those kinds of forms, but we try to. I do my best to try to set up a supportive environment where people don't feel judged. A lot of non-judgmental language, I think, is really important in those establishing those relationships. I wouldn't say that our healthcare system has a formal screening along those lines, like what we do with depression and anxiety, where pretty much at every visit you get asked basic screening questions about those things. So, I guess maybe both a yes and a no for an answer to that.
Yeah, and then there isn't a great screening tool. We talk about this all the time in our world. On a side, if we could see kind of what your paperwork looks like, I think that would be very interesting, just, to make us more aware, even in our clinic. Not that I would use your intake paperwork, obviously, but just it'd be great to see kind of what you use, just so then, at least in our clinic, to kind of make sure we're using kind of the same type of questions with the same type of language. I think if you wouldn't mind, I would find that very helpful.
Sure.
Eric, and the next question really kind of deals with, the mental health and addiction stuff. But from a pure mental health standpoint, suicide, of course, is a pretty significant risk in the patient group you serve. And that must be something that you really focus on as well.
Yes, for sure. Mental health and gender diversity are such complex, intermixed topics because the diagnosis we put in that we work off of is gender dysphoria, right? Which is the symptom, the distress experienced when who you are on the inside doesn't match what you look like on the outside. And walking through life parading like somebody else is awful, and it can cause a lot of mental health issues. And so, it's not uncommon for me to do a gender intake appointment, and it's problem number one, gender care. Problem number two, anxiety and depression, because and I'm almost surprised if that's not problem number two, because the two are just so intermingled, and walking through life in a non-authentic way contributes to anxiety and depression. And so very, very common, and it's pretty common for me to find that when they transfer to me that there's already existing diagnoses of anxiety and depression and mental health management in one form or another beforehand. So, and there's also I don't want to step on Mika's talk here, but there's also statistical connections with autism spectrum disorder. in the gender diverse community. And so I've, just by doing this, I've also learned a lot more about ASD management too.
Yeah. Do you actually have mental health care providers in your clinic as well, or you deal with as much as you can and then have to refer out?
We do even have an in-house counselor who's wonderful with my gender diverse patients. But there is also kind of specialty training in working with gender diverse patients. And so if it's somebody that we're recommending that they see a counselor, we usually ask for somebody with a real specific background and training in working with gender diverse patients. And so mostly we rely on a lot of the community counselors for a lot of that. We want somebody if somebody's just coming out as trans and they need to see a counselor, we want them to be a counselor that knows more about being trans than the patient does. And that's not every counselor. So we're pretty selective about that. And in that case, we usually refer out.
Yeah. And I think that...
Okay, can I ask one more question for please?
No. Okay, go ahead.
Just kind of along the lines of what you just said. That's why I'm interrupting you. One of the big things with like addiction care and in clinics is really kind of peer recovery, to kind of have that support system of someone who's kind of been there, done that. Do you kind of like incorporate something like that? Or is that a thing where you have these kind of, I don't say extra people, they're not official providers, but just to kind of help offer that support, navigate some of those things that patients may need that extra help with and support with, especially if they don't have that really close community of people. We had talked with Mika yesterday or the other day about, the community and like family community and patients who are higher risk for substance use disorders not having that community. So yeah, do you guys have something like a peer support built in?
If we're giving out resources on who's available in the community, we try really hard to keep track of the community support groups that you're talking about. We don't run something like that per se through North Memorial, because honestly, there are a lot of good gender support groups that are sort of often run by trans people, and I wouldn't pretend to say that I could do that better than what's already available in the community. But we do try to keep track of that and what's available in the community and give out those resources pretty freely.
I think we had most of the questions, but I do have one other question for you. But if there are people in the group today that were thinking, this is something I'd love to be able to offer in my community or be able to, help patients that are more rurally. How did you get started doing this? Are there certain kind of courses or different types of things that somebody could get more information on?
Yes, there are now, not back when I started. It just sort of fell into my lap kind of organically as an out gay doctor. Even in residency, I picked up lots of LGBTQ patients and I always had an interest in it. I was lucky enough to do some rotations at the University of Minnesota's Center for Sexual Health, or their PHS program. I'd say our model ultimately ended up being quite different from how they do things there. But I think you start with an open-minded attitude and do what you can to convey that. I know that a lot of the programs around Minnesota, that the gender care programs now are a little bit more robust in offering opportunities for students to shadow with them. And I think that there's a lot more opportunities now than there were back then.
Yeah. Okay. Perfect.
Well, thank you so much for coming on and giving us a little bit of your expertise about working with trans people and gender affirming care. I really appreciate it.
All right. Yes. Thanks so much, Dr. Haugland.
Sure.
Thank you.
Okay, so moving on, we're going to discuss multiple different surveys and studies regarding mediating factors of mental health challenges and substance use. This survey was conducted with 216 trans youth in the San Francisco Bay Area. And it assessed if patients had gender-derived issues in the following categories: trouble getting a job, losing a job, troubles in school, change or dropped out of school, changes in family or friends, and then difficulty with healthcare services that they perceived as being because of their gender. And psychological distress was measured with an 18-item version of a brief system inventory. They assessed depressive symptoms in the past week using the short version of the Center of Epidemiologic Studies Depression Scale. So multiple different associations were drawn from this survey. It found trans-based discrimination was associated with increased odds of PTSD, depression, and stress related to suicidal thoughts. Next slide. Continuing on that same survey, those with psychological distress did have increased odds of using multiple drugs, and increased odds of substance use after transgender-based discrimination was another association that was drawn. Finally, for this survey, they found that parental closeness was a protective factor and was associated with decreased odds of mental health challenges in these patients, which kind of makes sense. It's just their social support system. And just having that support means all the difference when you're that age. The next slide we're going to go to, or next slide, please, is also a survey. It included 600 transgender adults from Rhode Island and Massachusetts, and it was completed online. And it was, as you can see, it says, the assessment of the relationship between discrimination and lifetime substance use disorder diagnosis. It's important to keep in mind that this is a survey, so it was a self-reported diagnosis of substance use disorder. But it looks like 11.8% of this population noted that they had struggled with a substance use disorder, either now or previously. I'm just going to flip my page here. They filled out an everyday discrimination scale in combination with the transgender-related discrimination variable to attribute perceived reasons to their experiences of discrimination. So they were able to say, like, I think I was discriminated against because of my gender on multiple different questions. And otherwise, they found that trans-related discrimination was associated with substance use disorder diagnosis. And you can go to the next slide. And then the critique of this would be that that it's a survey. So everything that these patients are saying is subjective. Discrimination is not something that's going to be an easy thing to measure. So I think in some regards, a survey is a good way to ask about it, but it's also going to be relatively subjective and perceived oppression to an extent. Even though these patients really do undergo a discrimination. And next slide, please. Okay, so this next slide is not a survey. It was a VA study where they extracted a patient pool of patients with documented alcohol use disorders or undocumented alcohol screenings, and then other diagnoses. So the pertinent diagnoses that I'm talking about there are gender dysphoria that Dr. Hogland was talking about. And so they used ICD-10 codes regarding gender dysphoria. It looks like, so they had about 9 million cisgender or transgender patients altogether, and then 8,619 transgender patients in the study. And they found that alcohol use disorder, substance use disorder were, and then a combination of both was 8.6% of the transgender population for alcohol use disorder. And then for substance use disorder, it was 7.2% of the population. And then in the cisgender patients, instead of 8.6 for the alcohol use disorder, it was 6.1%. And instead of 7.2% for the substance use disorder, it was 3.9% of those patients.
So roughly half.
Yes. roughly half. Next slide, please. Perfect. They were able to look at social and economic barriers. In order to quantify the social stressors and economic challenges, patient charts, outpatient clinic stop codes, templated social work referral assessments, again, ICD-10 codes and clinical screening questions were utilized. And they found that social and economic stressors were 2 to 3 times more common in transgender patients. And next slide, please. So just continuing on with this, talking kind of about social and economic stressors. Slide 14. Okay, yeah, researchers were able to, again, affirm with ICD-10 codes and found that transgender people experience barriers to care at 2.8% versus 1.7% of the cisgender population. And then 31.6% of the transgender population had social and family problems, whereas 15.9% of the cisgender population had social and family problems. So that's about half again. Yeah, I think it's important to recognize the social and familial difficulties trans patients can have when they come out and people aren't accepting in their life. Next slide, please. Okay. And so in this group of trans veterans, you can see that the amount of patients that had experienced military sexual trauma was, almost 4 times higher than the cisgender population. And similarly with other victimization. Yeah, and I think one of the limitations with the study is quantifying social stressors and economic challenges is a difficult thing to do. And I think that, they did it in a way that made sense, but isn't necessarily the most objective means of getting that information. Next slide, please. Okay. So we're going to talk about the prevalence of substance use disorder in trans populations. So in the previous 2 studies that we just talked about, again, 11.8% of the population in that first Rhode Island, Massachusetts survey said that they had a substance use disorder. And in the transgender veteran community, 8.6% had alcohol use disorder and 7.2% had substance use disorder, as compared to 6.1% and 3.9% in the cisgender population. Next slide, please. Okay, I'm just gonna make sure I'm aligned on my paper here. Okay, so we're gonna talk again about prevalence and co-occurrence of substance use disorders. We have a study, a cross-sectional study from Optum Labs. Again, like the veteran study, it's selected by ICD-10 codes. They were looking for words like transgender, and then also we're taking a look at, co-occurrence of alcohol use disorder, nicotine use disorder, and substance use disorder. So the study included 15,637 trans people. And so it was matched on a 3-to-1 ratio. So 3 being the cisgender patients and then the 1 being the transgender patients, based on age and geographic location. And then they were able to further break up the groups into people that had substance use disorders and people that did not. And next slide, please. Next slide, please. Going.
Katie, do you want to go to the next slide?
Is this not the next? Did it not advance?
Oh, there it is. You know what? I'm sorry, it did. I just.
Okay, back up.
There it is. Okay.
Okay.
I just wasn't paying attention. So the prevalence of nicotine use disorder in this population was found to be about 3 times higher than in the cisgender population. alcohol use disorder was also found to be about 3 times higher. And then substance use disorder similarly, about 3 times higher. In the trans participants, cannabis use disorder was the most prevalent, whereas in the cisgender population, cannabis and opioid use disorders were equally prevalent at 0.4% of that population. But I think that's something that's interesting. In multiple of these studies, they found that nicotine or tobacco were more prevalent in transgender communities. Number 19. Okay, next slide, please. Perfect. Okay, the next slide is about veterans again. It was the 8,619 transgender veterans, and they went through the patient charts to look for alcohol use disorder, so OUD screens for alcohol use. And it looks like 8.6% of the trans population had a past year diagnosis of alcohol use disorder. And then the cis participants, however, did score higher in the primary outcomes of the study. So we're talking about unhealthy alcohol use, high risk alcohol use, and yeah, next slide, please. And that'll show up on the next slide that we'll just see. Yes, and high risk alcohol use and heavy episodic drinking. It was the other primary outcome that I couldn't think of. So cis people did score higher in that regard. And you go to the next slide. The next study that was included is a meta-analysis, 20 studies, as it says, comparing transgender and cisgender substance use. When it says, you can read through the list, when it says current use of specific substances, the specific substances or substance use disorders that are included are cocaine, amphetamines, meth, ecstasy, stimulants, heroin, opioids, cannabis, marijuana, LSD, hallucinogens, inhalants, and there was a few more on the list, but you can go to the next slide. This study did find, the meta-analysis did find that transgender people were more likely to use tobacco, have used substances throughout their life, or present current use of symptoms of specific substances. They found a similar likelihood of tobacco use disorder and other substance use disorders as the cisgender population, and actually mentioned that they thought their findings indicated that people needed to not put this as a label on trans people, that they're more susceptible to substance use disorders. So this was kind of an argument the other way, saying that maybe trans people don't necessarily experience substance use disorders as often. But it does seem, again, that tobacco is something that, or nicotine use disorder is something that trans people have, or is more prevalent in the transgender population. Going to the next slide, we're going to be talking a little bit about mental health improvements after people get access to gender affirming care. I think it's important to focus on this, when we talk about substance use disorder and addiction too, because considering future research, we would like to see, would studies reflect that people's substance use disorders improve once they get access to gender affirming care? I think that's an important future study. We do have some surveys and studies about that in the next slides, but I just thought I'd mention that. So talking about mental health, we have a prospective trial with 104 transgender and non-binary patients. There were 63 transmasculine patients, 27 trans feminine patients, and 10 non-binary patients. And then there was 4 kids that said, I don't know, which I thought was great. 69 of the youths underwent initiation of puberty blockers or gender affirming hormones. Go to the next slide. The results of the study found that there was the gender affirming hormones and puberty blockers were associated with 60% lower odds of moderate or severe depression and 73% lower odds of suicidality over a 12-month follow-up. So what they did is they did a 3-month, 6-month, and 12-month follow-up with these patients, giving them a PHQ-9 and a GAD-7 at each of those durations, and found improvements every time as compared to the youths that didn't get gender care, but also had said that they had gender dysphoria. And the limitation of this study really is that, and it's a sad limitation, it's that the youths that showed up to get care, they have, probably familial support and access to this gender affirming healthcare. So I thought that was an interesting limitation that the authors noted. Next slide, please. Okay, the next slide talks about the inverse relationship between affirming care and mental health symptoms. This is another survey. There's a lot of surveys on this topic. 288 trans people. You can see how that's broken up, listed below. 7.4% of the kids in the study endorsed recently taking hormones, and 31% had endorsed recently having gender-affirming medical procedures. Some of the associations that were made and the inverse relationship. So 7.3, disclosure of identity, use of hormones, and medication procedure engagement were inversely related with symptoms of stress. And we'll talk about how they measured that in just a second. Greater amounts of endorsed gender affirming care experiences were inversely related with symptoms of depression, anxiety, and stress. And then higher odds of attempting suicide, completing suicide, non-suicidal self-injury, there was higher odds prior to starting the gender affirming process.
Hey, Mika?
Yeah.
Can I interrupt for just 1 second? Because this is one of the points I had talked about me making was that, and I don't think I said it earlier, but one of the things I really love about my job is this. Like, we see this all the time. We're not involved in any of these studies, but I see so often such improved mental health if somebody can get on gender affirming care. It's often both literally and figuratively like interacting with a new person, because people can just finally shine and be who they truly were meant to be. And you see such improvement in depression and substance use issues and things like that if somebody can get on the right kind of care. I see it all the time.
It's interesting that you say that, because I think in the addiction world, we say that about patients all the time, how it's like a totally different person, for instance, on Suboxone a month down the road. And so you would say anecdotally that you see much less substance use disorders and such following that affirming care.
Yeah, absolutely. And depression and anxiety improvements as well. Mm-hmm.
Interesting.
Yeah.
Thank you.
Often we're able to stop anxiety and depression medicines or decrease doses once somebody's on gender affirming care, because, just in so many other ways, their lives start to improve that often we find that we don't need, not in every case, of course, but in some cases where we often find that we don't need the same medicines and pharmacotherapy they needed before.
Yeah. Would you say anecdotally there's a difference between patients when they have a really good family support as opposed to not, even when they get gender affirming care?
Mm-hmm. Yeah, absolutely. The background stuff makes a huge difference too. Of course.
Yeah, thank you for sharing and commenting on that. I think that's something even I saw when I was rotating with you, just patients weeks apart of starting and just being so excited about the next steps in their journey. And yeah, thank you.
I do have one question. Do you screen specifically for human trafficking and exploitation? And would you say that that's something that you commonly encounter in treating patients?
I think that was for you, Eric. Did you hear it well?
I did. Yes. Well, like I said, most of my intake appointments are an hour and a half, and so we get a really thorough social history. I wouldn't say that that's one of the things on the forefront of my mind in general. I don't want to try to pretend that it is, or that I ask specific questions about that. I think if I ever got a social history that would be anywhere along the lines of that, I think I would definitely pursue that. But I wouldn't say that I'm great about specifically asking about that.
Perfect. All right. Gonna finish.
Yes, thank you for answering the question.
Yeah, thank you, Dr. Haugland.
Where was it? You can go to the next slide, please. Okay, perfect. So there was multiple inverse relationships that were established. I think I went through some of them already, but disclosure of identity, use of hormones, and medication procedure engagement were inversely related with the symptoms of stress. Greater amounts of endorsed gender affirming care experiences were inversely related with symptoms of depression, anxiety, and stress. And then higher odds of the non-suicidal self-injury, completing suicide, or attempting suicide prior to starting gender affirming process. So after they started the process, those thoughts and feelings were improved. And so they used a depression scale. I thought I wrote it down, but I don't have it with me now. And they used I think the GAD-7, and then another test about, and on the GAD-7 and the PHQ-9, it has questions about suicide and the stress that it can cause, and how much stress that causes the patients. So they used that and were able to quantify it that way. You can go to the next slide. Okay, another survey. We have a lot of surveys. The survey was conducted in 2010. It included 314 transgender women in San Francisco. The survey used corrected logistic regression models to estimate odds for odd ratios, for binge drinking, injection drug use, anxiety, depression, and suicidal ideations. And overall, the findings indicated that transition-related medical care may reduce the risk of substance use amongst trans women. It was specifically conducted on trans women. You can go to the next slide. The limitations of this study were that this was actually an HIV surveillance study. So it wasn't conducted specifically to discuss, binge drinking, injection drug use, anxiety, depression. It was kind of repurposed to address that. And so it's not necessarily for substance use disorder. And also not necessarily to look at how mental health improves after gender care. And again, it's a survey, so self-reported diagnoses and the subjective component that brings along with it. We can go to the next slide, please. Okay, to talk about future research, I think it's important that future research includes prospective randomized controlled trials and not just surveys, with large participant pool, with transgender and gender non-conforming diversity, and also including definitions of and defining groups of the different gender diversity that they include in the study. So like trans men, trans women, gender non-conforming people, or breaking that umbrella term up into, gender queer, non-binary, gender fluid people, etc. I think that could be beneficial. So well-defined gender groups. And then it would be beneficial also if they had one psychological assessment before the gender affirming care, and then subsequently at 3 months, 6 months, and the 12-month mark, if they, in addition to filling out the PHQ-9 and the GAD-7, would also fill out, or would also go to a psychological evaluation. So then there's that like more objective component that a psychologist would bring to the table. I think that could be beneficial for these types of studies. Next slide, please. So there isn't a ton of studies on treatments of substance use disorder in transgender populations, and I think that that's it's important to recognize that. I think studies really just started booming, when there's been big transgender movements in the last, 10 years, probably, really making headway in 2015 in the media. And so that's kind of, I think that when I was looking at, research studies, that's really when the majority of them started to pop up. And then, COVID happened. So then there's also that put a damper on the amount of studies that could happen after. But the reality is a lot of the treatments of substance use disorder in transgender people at this point are just going to be pretty similar to what cisgender people are using. I do have some information about naltrexone and mirtazapine, but the studies are not super inclusive of many trans people. There's pretty low quantities, but I included them anyways just to show some representation of the transgender populations. So we can go to the next slide, please. Thank you. So there's a Peruvian study done on naltrexone. This one isn't necessarily to measure the efficacy of naltrexone in treating substance use disorder. This one was more to see if you could initiate both antiretrovirals and naltrexone at the same time when people found out simultaneously that they had alcohol use disorder and HIV. And the results overall showed no excess in clinical adverse events. No hepatotoxicity was noted based off of serum transaminase levels. So that's one study that I found on naltrexone, it included 11 trans women. So again, it's not like super inclusive, and there was 155 people altogether, and there was only 11 trans women. So, I think it is important to note that there is just more gay men. Who is the other population in this study? There just is more gay men than trans women, and so it's just easier to find gay men to be in the study. But there was 11 trans women, so that was some representation in that study. Then the next study was on naltrexone again, and you can go to the next slide. It included 120 men on 50 milligrams of naltrexone. It included men who binge drink and have mild to moderate alcohol use disorder. There was only one trans man in it. When I was looking articles up, I typed in, substance use disorder in transgender populations, and this one popped up because there's one trans man in it. So I just put it in there. I was like, representation, I guess there's a trans man in the study. But overall, it reduced the number of binge drinking days, number of drinks per month, and the number of the amount of cravings that the patients were having. So I thought that was interesting. And but the primary endpoints again were the number of drinks in the past 30 days, any binging in the past week, number of binge drinking days in the past week, and then number of drinking days in the past week. And those were the results. Obviously, for trans men, it's not super trustworthy because of the low amount of trans men. But next slide, please. Okay, and again, a small amount of trans women, but this one was on mirtazapine for the treatment of methamphetamine use disorder. They measured sleep, craving, dependence, severity, and adverse events. And then they serially measured urine samples and dried blood samples at 12, 24, and 36 months to test for alcohol, or I'm sorry, to test for meth. And they found, you can go to the next slide, reductions in positive urine tests at 12, 24, and 36 weeks. And then in symptoms of depression and insomnia severity at 24 weeks. Yeah, so that's some of the research on the treatments that has come out recently. There really honestly hasn't been a whole lot of recent research on substance use disorder in transgender populations. I think it's kind of a niche thing to study, and it's an important thing to study though. So I'll be interested in the next year's post intense COVID to see more studies on this come out. The next slides are kind of, just considering social determinants of health and important considerations and tips for working with transgender patients. You can go to the next slide. The main ones I want to highlight for this first slide are to ask your patients how they want to be addressed. On their profile, it says their name. And sometimes you have to go into their chart to see their preferred name in quotes, or, even farther to see or you might just even have to ask. But I think it's important. Yeah, ask your patients how they want to be addressed as far as name and as far as pronouns. And then ask about when you're getting to know a patient, I think it's important to ask about their support systems to get an idea of how they're doing with their transition. And I think it's important also not to assume that they, necessarily want surgeries or want to be on hormones, but to address them how they want to be addressed, regardless of those realities. And then the next slide, please. So this is just some of the social determinants of health that transgender patients can, that affects transgender individuals. And it's social determinants of health that affect a lot of people, but just other considerations, the lack of insurance coverage and trying to get gender affirming care, transportation barriers, having multiple layers of being in multiple different marginalized communities, et cetera. And then there's also a lower the quantity of gender affirming providers is getting bigger over time, but there still is a low quantity of gender affirming providers. And so I think it's important to recognize that, it's sometimes there's wait lists. Next slide. Yeah, so then the main points, you can just kind of read through those, but I think that the main ones that I wanted to hit were that the high prevalence of substance use disorder among transgender individuals is thought to be due to the combination of all those factors that we talked about earlier. And it's as a coping mechanism, just as it is in a lot of cisgender patients for some adverse experiences. And then next slide, please. And I think, and the first one, I just emphasized the social support component. It's important to, ask about who people have in their circle, who their family is, who their chosen family is. And then additionally, more research is needed on this topic to really get an understanding of the prevalence, the confounding factors, and substance use disorder and transgender populations altogether.
Perfect.
Yeah.
I think that having listened to this, I think to me, the studies that I'd love to see done are really what happens to that substance use disorder in a couple of cases. Number one, if they have parental support as they're going through this journey, as opposed to they don't. And I think also what happens to that substance use disorder to really see and to be able to kind of tell what that is as they go through that journey as well. I think those would be amazing studies, and I suspect that they'd really show what a difference it makes. Right? Any follow up anything else you wanted to say, Dr. Haugland? I mean, as we as we kind of end our day?
Nothing else immediately comes to mind.
All right. Any questions from anybody? There's Sarah McCumber. Interesting that you never hear enough about the mental health and substance use disorder and about the gender issues in the media, and that's true. I don't think that we do, and I do think that that's something that when we have a gender clinic as well, and they actually do a fair amount of addiction care there that we often don't get involved in, although I have been involved in some, but certainly needed. So any other questions from anybody before we let everybody go?
I have a comment on that last point about access to gender affirming care. I think it's kind of interesting that geography is starting to become a major social determinant of health, and that Minnesota is a little bit of a haven for it. The legislature has recently passed the ban on conversion therapy, but our surrounding states, North Dakota actually has a ban on gender affirming care. And then technically from the provider standpoint, I'm not sure that they enforce it, but it actually technically can be considered criminal to administer gender affirming care. And I believe Iowa is also going to, pass that legislation even this week. Texas has it. There's a lot of that out there. And so it's just very interesting to see. I mean, hearing Dr. Haugland say how he sees all of these outcomes change in a magical way once they get their affirming care. I just find it paradoxical that society in some regions is going the opposite direction, it seems.
Yeah, I think that to me, it is. I had no idea that was that way in North Dakota and some of these other places. Were you aware of that, Dr. Haugland?
So I think it's South Dakota that's passed a ban on pediatric gender care, and Iowa was looking at the same thing. It's not for adults, just pediatrics so far.
And it is the pediatric population. That's right.
So those of us who do pediatric gender care actually just had a whole little meeting, this in Minnesota, here in the Twin Cities, had a whole meeting this week about how we're going to respond to all of because there was already 9-month waiting lists at most of the major healthcare systems, and then we're getting patients from South Dakota and Iowa now. And yeah, it's very frustrating to see the news article where the legislatures are saying that it's to help prevent, help protect kids and help with mental health, because it does the exact opposite. And every medical professional that they get, who's mainstream, will say the same thing. And so, those of us who are actually working with trans people and gender diverse people all the time can easily say that access to gender affirming care helps in many, many ways, including with mental health issues.
Yeah, in a way, it's like you can legislate that stigma is okay.
Yeah, true. Yeah.
That's basically what's happening. And we were having a conversation, I think it was in the last day or two with Mika, about how when you look at patients with gender issues and they also have addiction, how now you combine both these stigmas. And this is a patient group that just frankly has so much difficulty accessing care and getting appropriate care. It's just, and then you put them in jail. And I've seen that. Okay.
And we tie our healthcare to working and insurance. And so then you lose your insurance and then you lose your access to your hormones, and it can be really devastating. It's a vicious cycle.
Yeah, we've seen when we were doing some jail medicine, we've seen people with, on hormonal things that they get arrested for a drug charge, and then suddenly everything comes to a screeching halt. You talk about a mental health crisis. It's just, and that's okay. Right. It's okay in the jail, apparently, to treat people like that. But it's a very poorly taken care of patient group, without a doubt. So something we all can agree on this call, I believe. So, all right. Anything else? Otherwise, we'll let everybody go for the week.